that would actually determine what you gave and monitor. That was the way of monitoring sugar. Of course, after that, the glucometers followed. And now we are into CGMS in a big way. I think so. There has been a change. The other aspect is apps for patients. So wearables and apps, that is, and for doctors, software, use of software in the clinic. So I've been using softwares of various types since the year 2000, and I have more than 50,000 OPD data, patient data recorded. So 50,000 patients have been registered on that. So it's been a long time, and I've seen how it helps me. I think having the history whenever you get a phone call from a patient, that itself makes a big difference. And now, of course, I have everything on my mobile. So even if a patient calls when I'm home, I still have the data accessible. I can talk sense, and I don't have to remember. It is practically impossible to remember all these things. So in these three areas, I think from the doctor's point of view, having a software in the clinic, then wearable technologies for patients that give you much better control. And the third aspect is, of course, various apps that have come up for patients. So these are extremely good.
Right. Well, you touched upon these elements of devices and wearables that have come up, and like you said, we've come a long way from the Folin-Wu method to now having CGM and a lot of data that comes in through it. What role do these devices play in approaching how it helps patients? B, would also want to understand how it helps you as a clinician in judging things when you get. Sometimes there is a lot of data overload, right, with all these wearable devices as well. So as clinicians in practice, we are worried that what do we want to do with 1,500 data points of blood sugar? What insights do we gather from there? How is it helping us? Whom do we want to use those wearable devices on? Is it for all? So these are some routine day-to-day decisions that we have to make, within those few seconds in the clinic when we see the patient. And an experience from someone like you will really help our audience to understand where this wearable technology is, where you are using in your practice, and how it's helping you and your patients.
I think that's an important question. I think if devices were very cheap or cost was not an issue, I think we'd be using it in about 70 or 80% of patients. I think particularly when patients are newly diagnosed with very high sugar levels, that is the time when you tend to start off with high doses of medicines, and the patient also goes on a diet at the same time, starts doing exercise, and there are chances of a sugar crash happening, hypos happening. And if you don't give adequate medicines, then the hyperglycemia is not adequately controlled. So that is one area. The second is where there is, if the patient's diet is affected, say post-operatively, that is one area. If the patient's diet has dropped or changed drastically, that is another. So a couple of weeks of monitoring the glucose, that is extremely important. And then sometimes you get bedridden patients whose intake is not predictable. And that time, of course, instead of monitoring with a finger prick 6 times, the wearables offer great facility. So those 2 or 3 areas are where I am using most of the wearable devices. So OPD software is, of course, now for everyone, and my patients appreciate it. On my OPD software, I have a little thing written. This tablet is for diabetes. This tablet, and that I've written in Marathi, Hindi, depending on the language of the patient. And that can be sent by me to the patient digitally on WhatsApp or email. Or even as a SMS. So patients appreciate that very much. So they are not discontinuing the important tablets. Then I think getting an idea of diet, what diet the patient is taking. So through the apps for the various programs like Fitterfly, you get a very good idea of what the patient is actually eating before you recommend any changes. So those are areas where I'm particularly focusing on. It's still not required. Of course, if someone comes with HbA1c of 7, you don't require a wearable. You're going to talk to the patient, advise about the diet, start off either on a very low dose of metformin, or maybe not even start off on a medicine at all. Watch it. So in that situation, you don't need a wearable device, but a diet chart can be very good. In the
Right.
OPD, when you get a huge number of sugar readings, I think what is useful is the patterns where you are getting hyperglycemia or hypoglycemia. So you can glance at those very quickly, and because you're getting patterns at different meal times or after exercise, then you can recommend changes in the medicine at that particular meal, or you can recommend a change in that meal, or reduction in the dose before exercise. So all these things help. Or when people are undertaking fasts, that is another area again where it's very helpful.
Right. No, I think you've touched upon all those elements. And when spoke about all these different patient types, spoke about languages also that, that helps the patient in different way. We see a large different kind of demographics, right, within our country as well, and within the diabetic population. Lot of, middle-aged population, a lot of elderly people with uncontrolled sugar. There are younger ones as well. And
Yes.
within all of these, now, I do see any specific challenges because there are so many patient types, right? And then choosing, say, the right candidate for a technology, like you said, for CGM or somebody who can adopt to an app. And there's an aversion, right, within your demography of patients as well to use technology, to understand it, to do all those elements. Do you see any specific challenges while we as a clinician, would want to do the best for the patient, want them to give us all that information, all the highs, lows, monitor their sugars in the right way,
Yeah.
monitor their diet in the right way so you can choose the therapy, modify doses accordingly. But there's always a barrier, right, where people don't expect a doctor to say prescribe a device or a technology to them. Then they only expect that, okay, I should get medicines or injection and at the most some advice on what to eat and not to eat. But
Mm.
how do you cope up with that,
Yeah, I think that's a very valid question. I think we have people to explain how to use a glucometer. We have nurses who explain the use of a glucometer. For the CGMS, the person who puts on the CGMS will spend some time with the patient and explain how things are done. About the diet as well, I find in the OPD, I cannot personally go into the details of the diet. There are limitations of time, and of course, there are limitations of my knowledge in that area as well. So I find dietary programs, dietitians, very useful, and particularly programs that combine all the three aspects of diabetes control. So your diet, exercise, and psychology, if these three areas are combined, these are extremely useful. So you're addressing all the important points there. And I think that the amount of time that needs to be spent with patients when you go into the specialist area, this is done. I talk to patients and I tell them my OPD consult will be 2 minutes for diet. And in that 2 minutes, I tell them stop sugar, and then I said, if you feel your wheat is increasing, your test for a month, stop wheat and use jawar bhakri, one small bhakri with one katori of vegetables, one katori of salad, and one katori of dal. You work in that ratio. So that gives, yeah, that limits your refined carb or grain intake. And that is how I work. So this is my 2 minute diet consultation. And in the OPD, if you're seeing 30 to 40 patients in a few hours, that is all really you can give. And some people for that, for them, that is enough. You know, they'll cop on to that, they'll take that, and then, but other people want many more details, specific food items, how much quantities and this and that, they'll need more details. So I think in that situation, a diet program is extremely helpful, and the time spent with patients is high. I find very good feedback from patients. Of course, despite doing a diet program or being with a dietitian or a physiotherapist, some people will still not do it. They'll talk about it, they'll read about it, they'll pay the money also, but they falter in action. I think all of us have experienced that in ourselves also at in the higher or lower degrees. So that is something that I find. But in general, I find that use of these devices increases your success rate of achieving a good HbA1c, improving the patient's quality of life. The other challenge is a lot of patients are elderly. So using wearable devices can be a major challenge for them. And that, of course, it's not that they can't use them. They can use them, but more time has to be spent with them. And similarly with the apps also, I think someone has to sit. And so I think it's well worthwhile having an educator in the clinic who will go through all of this with the patient. So generally, I tend to keep little meetings where 10 or 15 patients are called and we go through all these devices with them and explain the diet in greater detail. So that's how I approach it.
That's very, very well explained, and I think good take home for our audience also, because a lot of doctors also, struggle to explain the benefits of technology. And, these are challenges that everybody faces, but somehow, we don't get past it. We try to just tell the patient, okay, we have some offering like this, or you can try this. Like you said, I can give you only 2 minutes of dietary advice, or only this, which is very limited. But if you want something very detailed, personalized, and more long going, maybe these things can help you. But it's sometimes a struggle, right, between us and
I
the
think the
patient.
cost has to be mentioned upfront. I think
Okay.
that has to be clarified. And you have to emphasize that this cost, which you're seeing as a major obstacle, will result in a reduction in your medicines. So that cost, there will be a cost saving. Plus, it will probably also reduce your hospitalizations and diabetic complications, which are a major burden.
Right.
As the years go on, we will be spending more and more on hospitalizations and diabetic complications. So once explained in that way, a lot of people actually see it properly in the proper
Right.
perspective.
Right. I think that's right. I think explaining, how it benefits them and the value of it rather than the cost of it. I think that's a conversation that we should have with them. This is quite helpful to explain it to different types of people, right? Everybody is different in terms of their adoption to technology, to adherence to all these lifestyle measures as well, right? Some people want shortcuts where they just want to take the pill or even be on insulin. I've seen patients who will tell me, give me an injection, but I'm not going to have a restriction on diet, etc. So we have seen people of all types, and this is quite helpful when we explain them. And for coming to buzzwords, that we started with, and now we have AI coming up in all ways, right? You open social media, open any doctor WhatsApp groups, all studies, everything, people are talking about it, right? To the extent of, can AI replace doctors? And I just today morning read a post where the WHO has said that, AI can be dangerous for medical diagnosis. And there are other counter things which say that, they've cleared all medical entrance tests and they've cleared the USMLE and the board exams and whatnot. But coming to very practical uses, right? We don't expect it to be very, very path-breaking in many ways, because, medicine is an art as much as it is a science, right? So we can't expect that. But what do you think, and why, where, some small changes where we can safely and freely use AI, or that's already happening, or in a way where you feel that this is where AI could help us?
I think it is happening to a certain extent. I think all the CGM devices are actually predicting hypo, and they're predicting hypo quite well, and they warn the patient. So if they see the trend of sugars falling, and there'll be an alarm, so that works extremely well. So to that extent, now the other application, I suppose, is if you give a meal plan. See, I'm going to eat this, this, and this. What dose of insulin should I take? That will be something like it. I'm sure AI will work very well, and whether it can personalize it to that particular patient is the challenge. You can have general recommendations, but looking at that patient's response to particular types of tablets or insulin, can that be personalized? Will AI do that? I think that's still questionable. We don't know. We'll find out. But I think either rejecting it altogether or accepting it without any precautions, both are extremes. I think we have to take it up step by step, as more and more features are validated, proven useful, and we can use those. The human element has to be there. I think that is not going to go away. And whether AI is going to help us in diagnosis, it will probably help us in diagnosis, in getting rare diagnosis, and suggesting investigations. But the person has to be there as well. The doctor has to be there. So in that sense, I don't think doctors are going anywhere. I think we'll be helped by AI. I'm very optimistic of it, that it will help improve our standard of care. It will help improve outcomes for patients. I'm not scared of AI in that sense. And they're not replacing doctors either. I don't think that will happen in the foreseeable future.
It's very true. I think, takes back to the time, and a lot of people are drawing that analogy of when computers came and people, actually asked Bill Gates, is this going to replace humans? And every time a technology makes an advancement, people, start making these assumptions. But it's great to hear from you that we shouldn't be threatened by AI and probably use it, in the right way to help us, to support us. Like you said, to make diagnosis. I just I heard about an Oracle AI yesterday, which is updated with all up-to-date guidance, all the guidelines and everything. So you just ask it a question and it'll tell you what the guideline exactly is telling you at that given point in time. So in a way, it helps us, to make the right decision in a short span of time as well. So I think up to us how we use it and take it, but not shying away from it, I think, is one lesson that I've learned today from
I
it.
think one thing I find is that when I graduated and did my MD also at that time, most of the drugs that were in use were contained in the 2 volumes of the pharmacology textbook of Satoskar and Kare. And I knew at least every drug by name at least. And many of the drugs I used to know what they do. Now the range of drugs is so high. If we hadn't got a Google search and all these things, I don't think we would have been able to manage, because the side effects from all these drugs, because of Google, we are able to look them up. And the brands that we see in India, that is again the huge variety of brands. We have Google, we can search it. So that's the use of AI in a way, I suppose. So we have great uses of it. Now, another use of AI, if they can figure out doctor's handwriting, I think that would be great. That is something I find. Handwritten prescription. My own handwriting is also terrible. And when I see handwritten prescriptions, I have a hard time deciphering what they're saying.
So we have an AI team within our organization here, and this is something we also, as doctors within here, joked about it. And he said that that's one point where AI will give up. So it's like, if you ever want to defeat AI to your intelligence, I think just give them something that you all have written, and it will
Yeah, that's true.
not decipher it in the right way. But that's, I think, the dream of AI that we expect, that they can actually read our prescriptions in the right way. Great. Uh, also when we talk of all of this technology and many things we hear, right? And uh, you said the human element has to be there, and with that comes in the ethical component as well. Right? We have to make sure that because people are apprehensive today with the way data just flows through. You enter your number somewhere, and then you keep getting, I don't know, hundreds of
Yeah.
calls or spam messages, and people are really worried now that what's going to happen. Even they're taking so much of my data, be it my health profile, be it my blood sugar, be it diet, be it all that. Are are they going to like sell it off? People keep talking of data being the new oil, and there's a lot of skepticism now when it comes to people filling data. While it is to help them, but there's always that fear that, okay, is this going to be misused, or is this going to be used for commercial purposes, etc. So where do we draw that line? What is your take on the ethical considerations of all these apps and data and healthcare?
Yeah, I think one of the things that I find useful is soon we will have a digital health record, a national digital health record, and that will be password enabled. So that will be good. One thing it will stop is it will stop people from taking false insurance claims. They'll take a policy denying pre-existing illness, and then they have a bypass in 6 months. So that happens very frequently still. People take up an insurance policy only when they find out they have a certain disease and they know they're going to need an expensive treatment. So that is one area on the positive side. On the negative side, of course, a lot of companies have come up which are probably not functioning ethically. A lot of software companies which give you doctors free platforms to use, and the data that the doctors enter is taken up, and then that data is used to market lab tests and pharmacological treatments, various online pharmacies, etc. To those people. I think that could be a source of major problems. Whether that data also could be used for some other criminal purposes, that is also a possibility. So that is something that really worries, is a cause of concern. And I think we have to make sure that the companies that we are using are really good companies, that they make their money from their stated purpose. So if there is a medical record company, they should charge you their fees for keeping records, and that should be their source of income. They should not be offering you something free and at the same time earning by selling patient data and doctor data to a multitude of vendors. So I think that some legislation will be required in that area. And I think as doctors also, we have to be very careful what companies we choose to share our data. Cloud-based storage of data is so useful. It is so useful, but make sure you have the right partners in that. Don't go with anyone who does what is almost a criminal activity of selling data.
Right. I think well said. And the choice is ours. We should go with.
Yeah, we should be prepared to pay for the service that we get. That is the only way. Like patients pay us fees, we have to pay the service provider a fee.
Right. Absolutely. Very fair. You spoke about, we touched upon communication between healthcare providers, patients. We are all crunched for time in the OPD. Indian OPDs are quite busy and flooding, and patients also have endless questions sometimes. And while we want to answer all of that, on an average, we've seen, that multiple surveys also that have done that says that a lot of people are not, completely able to give as much time as they would want to. So at both ends, right? As doctors also, we feel guilty at times that we've not been able to do full justice to every patient, given that there's limited time in a day that you can give. And patients also at the same time feel that I had so much to ask to my doctor and they probably couldn't tell me everything. With all these advancements in technology, with apps which also support in terms of educating patients, guiding them through different experts, etc. Do you think they will help us bridge this gap, especially the communication gap, where we want to educate them the most? Some of us have the luxury of having diabetes educators in our clinic who can spend enough time with the patients, but again, it's like a one-time thing. Only when they come to the clinic they get it. So, do you think this advancement and moving in this direction is going to help us bridge that potential gap and in turn help patients be more aware, make better choices for their healthcare and get better outcomes?
I think definitely. I think we have to be smart about it. Depending on how much time we need to spend with that particular, say a patient is in deep trouble at that moment, you need to really spend in half an hour, 45 minutes. I will generally ask the patient to go and lie down on a bed. I do my OPD in a hospital. So I'll ask them to go and lie down there. We'll run a few tests, and through the day, I'll keep coming and having a look. And if that patient requires admission, then as the test reports come in, we'll admit the patient. Other patients have a lot of questions, but there's no emergency. So for them, I generally will say if things are very crowded, that we'll schedule another appointment where we can go through these. And I encourage them to send their questions on WhatsApp. So I have a WhatsApp session every afternoon where I deal with all these questions. Some of them can be answered very, very briefly. And others need detailed explanations that we can do on the phone, and I can send revised prescriptions on WhatsApp. So that's something that I'm doing regularly. Besides that, I'm very keen on organizing small patient education seminars. A lot of doctors actually use YouTube very effectively for that. They have their videos about diet and this and that. So that is something I haven't ventured into the field yet, but I think that's a great way of doing it. And I generally tend to go with small groups and hold a session for newly diagnosed diabetics, and we'll discuss diet with them, or we'll discuss various groups of medicines, or we'll discuss complications, exercise, all these things. And I generally will call in specialists in that area as well. So that works very well. And people come to the hospital. We have a hall, fortunately, available to us. But otherwise, those who don't have halls can rent out a place somewhere close by. And that works very well. So we have to be very proactive in our communication. I think that helps a lot. And we have to talk to the family members also, because I think a lot of our elderly patients have caregivers. So even if I always tell the elderly to bring along their caregivers, if possible. I'll see them on a Sunday if required. When I'm going to do a round, I'll call one or two patients on that day if the caregiver doesn't have time off. So that is something that works. I think good communication with the caregivers. Another area these days is we have a lot of patients with children abroad, and they're extremely anxious about what's happening to their parents. And again, having good communication with the children, I think that gives a lot of satisfaction to both the patient and to us as well, and that we are available for them. And creating your own backup team also. I think creating a team around yourself is so important. Creating a proper digital environment around yourself is so useful. And having a good internet service provider which doesn't break down frequently, having power backup, all these little things go into making your service more efficient.
Right. I think I really like the way you put it, in terms of patient centricity, all these elements are quite important. And when we typically talk of caregivers, we generally talk of debilitating diseases or where people require those. But it's a very important aspect which is ignored even in chronic health conditions like this, particularly with the geriatric population or those who need care or those who are living alone here without their young ones here and the empty nest. So I think all these elements are really great, and it's great you take so much of effort in terms of truly being patient centric and not just using it as a buzzword, as a lot of people unfortunately do, that they claim to be patient centric, but the execution is not so much. So that's great. And with that, can you also share, with all said and done, with all these things that we've done with technology, etc., have you seen some great, you mentioned earlier that there seen some good feedback, etc., from patients coming in, but are there any notable anecdotal incidents that you would like to share where technology has helped you make better choices or has really helped the patients and they've come back to you and said that, thank you for recommending a technology like this too?
Yeah. I've been involved with quite a lot of diet programs. Dr. Jagannath Dikshit's program. Some of my patients also have done Freedom from Diabetes. A lot of patients also go to Fitterfly. So I generally give the patients a choice. See, these are the things available. See what suits you. And in each and every one of this, there's a particular advantage and disadvantage. So you have to make sure that the patient should really look at it. It's like a supermarket. So you have a good few choices. You have to make judgment on one of those, try those. If that works, that's fine. Otherwise, you shift to another one also. So I think that works very well. And a few things that I found, one of the patients, without the use of technology also, I've seen that just on this 2-minute diet consultation, I've had patients lose 20 kgs. just on the 2-minute consultation that I was telling you, and come back to me 6 months, doctor, my sugar is normal, I'm off all medicines. So some patients can grasp things very quickly. They can get to the moot point, and they can quickly identify what's on. Others will need more hand-holding. Majority will need more hand-holding. And that is where I think these technologies come in. So they'll have multiple questions about quantities, types of food, jwari, bajri, gahu, all these things, what they want to eat. So all of these things, we see spectacular results more reproducibly when they are in a system. It's like going to school. It's like going to school. You're going to get more 10th pass if you are in rather than if you're doing a freelancing thing. So I think having programs and enrolling patients onto programs works extremely well. And dramatic changes, we have seen many reversals. Not one, there are multiple areas where I've seen the complete reversal of diabetes, particularly people who are in HbA1c range 7 to 8. They go back to a non-diabetic status completely, and they remain so for years and years. So that is something I see on a very routine basis, because when I started my practice, I was also of the mindset that once a diabetic, always a diabetic. You are a diabetic for lifetime. Now that very question, that foundation is being seriously questioned, and we are seeing results with programs. And 5 or 6 kg weight loss now is pretty common for most of our patients, and we see a reduction. I think it's the motivation that works. For some people, I've noticed that psychological stress is an important issue, and so guiding them towards appropriate programs that deal with this issue. There are many meditation programs, just psychological counseling programs. They work extremely well. And diet programs like the Fitterfly program, which incorporate all three, are excellent in that respect. So I've had multiple successes with all the types of programs that I've used. And it's just a matter of asking the patient to give the patient the freedom of choice. They can choose what program they want to go on to. Let them talk to the person concerned. Then let them look at the finances, the practicality of the program, and then they can decide. So one of my patients who had a severe coronary artery disease in her 60s, and extremely slow flow in the coronaries and angina. And she came to me. She is a doctor's sister, and she came to me, and we enrolled her in a program, and she is completely off medicines now. She doesn't require any anti-anginas. She's lost about 15 kgs of weight. So, and this type of thing is a very common occurrence. Of course, we get a share of failures as well. It's not that the failures are not there. And we have to identify where we have failed to put across things properly to patient, and where the patient is not making the mark because just lack of motivation and everything. And then you have to identify, look, this is the thing you need to do. And that's how I work, customized care. So programs are a great way of increasing my success rate.
I think very well said. And at the end, when you spoke of customization and personalization, I think that's the key, right? We've been talking about personalized medicine for many years now. And actually, with the advent of all these technological advances, we are able to reach closer and closer to that personalization of medicine for people. And I really like that you give them that typical cafeteria approach they used to teach us in public health about, where you empower patients and make the right choice.
One thing, I don't know if I mentioned it to you before, pharmacogenetics is also an important area. And now you have, for a spend of 5 or 10,000 rupees, you can get a list of drugs that will suit you and that will not suit you, or that will be obvious, very harmful to you. And that probably is a once in a lifetime spend that it's well worthwhile having. So that whenever you prescribe statins or aspirin or clopidogrel or whatever anti-diabetic drugs, you already know that this drug is more likely to suit me.
Right.
And I think that can be incorporated into a lot of the programs. And if the volume factor were there, I think the costs can be brought down. I have unfortunately been unable to convince people in a big way about spending a few thousand rupees upfront just to find out what drugs suit you. But I think that if that were incorporated into various programs, that would be something that would be more easily taken up.
True. I think the more the scope of things broaden, and like you said, the volume increases when more and more adopters are there of this kind of programs, things will come down. We hear a lot of work happening in this space, right? In terms of genome analysis, in terms of, and big players are now entering in. Reliance has entered into in genomic analysis to actually find out disease risks and everything. And I think for a few thousand rupees, they create a complete profiling for you. There are other such companies as well in terms of genetic analysis, risk propositions, and pharmacogenomics. So I think it's great. I think we'll open it for the audience. We've already received one question from Dr. Rakesh. It says, of course, there's a compliment to the session for you. It says, what is your real life experience regarding activation level and distress level among diabetic patients, and whether these patient-centric approaches can improve the quality of health in the short term, or does it require longer intervention?
I think sometimes it works in the short term, sometimes it doesn't work in the short term. And I think if we consistently keep telling patients those, sometimes I find that if you just keep repeating it without antagonizing the patient or without putting getting into a blame game. So if you just keep repeating it, at that moment in time, whenever that patient is receptive, you will get through. I know a patient who have been who's undergone multiple surgeries, angioplasties, etc., for heart problems, and he still continues to smoke. He's been to psychologist, psychiatrist, everything, but every visit, I just keep telling him with a smile, I think if you haven't stopped smoking yet, please do consider stop smoking. That will reduce your medicine. And one certain day he comes to me, and one of the visits he tells me, Doctor, I'm off it. So you've been telling me for so many years. Last time you said it worked, and I've not had any cigarettes since we last spoke. And I don't know what happens. Something changes, but your message has to be consistent, and I think that is also without arousing any guilt feelings in it. That's something I find. If you blame them, hey, you'll be dead, you'll be this. I don't use that terminology. तुमचा photo भिंतीवर लागेल. That type of I find it doesn't work. It's counterproductive totally. So sometimes just tell them that they'll be much better. They'll be much better. That you look forward to seeing them off the cigarette. I think that approach I find works much better for me at least.
Yeah. No, I think very well said. And fear mongering is something that traditionally we've used a lot in healthcare, right? I've also seen all seniors and everybody threatening patients in the wards, right? Particularly patients with liver disease and cirrhosis, or patients with triple vessel blockage, anything pertaining to their lifestyle in terms of smoking and alcohol that has caused it, and literally threatening them and then telling us that this is probably the language they understand. But things have changed, right? We are now talking a lot about empathy in communication. In fact, when we get patients on Fitterfly programs, we do a diabetes distress scale for them. And turns out, people have given answers in terms of physician distress, not because, and we thought the reasons would be like doctor didn't give enough time or doctor didn't explain this or something. It's more about that the doctor scared me. So the distress increases for them if when they are asked that all the complications of diabetes, and your kidney will fail and your eyesight will go away and all of that, and patients actually get more distressed because of that rather than being motivated to do it. And like you said, that approach is really right, where you keep checking in on the patient and telling them, rather than telling them at one go that if you don't do this, you're going to get a stroke or something. So I think that change in communication is really important. And, you have summarized it very beautifully with an examples. I hope that helps Dr. Rakesh talk to his patients also accordingly.
Yeah, I think one of the things that I find in the last 30 years of my experience is that what works is if I improve as a person, I'm much better service to my patient. So one of the things that I've been doing is trying to improve myself as a person. And to that end, I am a regular meditator. For the last 23, 24 years, I do Vipassana courses once a year. And I recently even ventured to do a 30-day Vipassana course a couple of years ago. And I found something like the Landmark Forum, which my daughter recommended to me. So, and I found it extremely valuable. And I think all of us must search what works for us to improve us as people. And once we improve as people, our communication will improve, our outcomes will improve, our patients will be happier. I think our families will be happier. I think that works very well. So I encourage those who haven't tried any of the self-improvement. Some of us are, of course, so busy that there's no time for that. But of course, you have to make time. You have to make some time for yourself. And if you try these, I think you'll find that everything improves in life, actually.
Right.
Just not just your personal life, but your professional life, and patients' lives will improve as well. Let me share a very funny thing with you, 2 minutes. One of my patients, this was abroad. He was about 70 and he had a aortic valve replacement and was diabetic. And he was a widower. And he came to me one day and said, Doctor, I've started seeing this lady and she's 60 and she's invited me to a weekend for just the two of us. And I think she expects me to have sex with her. Do you think my ticker will be up for it? I said, your ticker is fine. As long as you can rise to the occasion, you should be okay. So we had a great laugh. And he came back and told me, yeah, it worked. So, and I think a bit of humor in your interaction works wonders. I think that is something that I've found. So a little bit of joking, even with the most bedridden and dying patients, actually it cheers them up like anything.
I think we should actually plan something just on doctor-patient communication with you. I think you have such a very different demeanor when it comes to talking to patients and doctor of all types. And with all this patient centricity, I think the next level is talk that communication. I think so.
Yeah. I think I was a terrible communicator. And it's just by experience and active effort I've improved a little bit.
Great. Thank you so much for sharing that. And we have two more questions. Dr. Iyer asks you, how do you convince patients to use technology and digital programs for diabetes management? So you mentioned you give them the choice, but is there a step that you take? Because I'm sure that there could be an inhibition at times to begin with from the patient's end as well. And even as doctors, I feel, there is always a bit of clinical inertia that we also still have, in terms of prescribing, saying, what will the patient think? That, is it a question of my competency that I'm prescribing a digital program, or is it some other association that the patient might, draw some conclusion about it? So how do you, with all these wonderful tips and tricks that you're sharing in terms of talking to patients, I think it'd be nice if you could share your input on this as well.
I think I try to understand where the patient is coming from. That is, if I can understand that, it might be just mistrust. It might be some people have a terrible concern for finance, even though there's no shortage of money. They're just stuck in that. No, this is too much. This is too much. If you tell them your fees is 100 rupees, they'll say, no, this is too much. Give your consultation for 50 rupees. So some people have that mindset. Others people are actually genuinely poor and they can't afford it. And I try and make out what category that person is. And then I try and offer him a solution. And then I ask them to also communicate with someone who has undergone that process. So if someone who has undergone an angioplasty, then I'll tell them, talk to these few people. And of course, I take permission from those people that this person might call you. Similarly, for CGMS, usually there's someone around in the OPD who's using CGMS anyway. So I invite them to talk to the patient for a minute or two. We talk about prices, and for people who really need that and for whom price is a big issue, then I actually talk to the vendors and see what they can do at the best price. So that trying to see which mindset the patient has. And I think once I can identify that, I can convince them. I don't really have to convince them then.
Right.
In that sense, if I can emphasize the importance of that thing to them, then
Right.
they will change over very quickly. For example, if we use a technique called external counterpulsation, EECP, for heart patients. And it's a wonderful technique. I've been using it for many years. But it's not a replacement for bypass surgery. It's
Right.
not a replacement for angioplasty. It's a complementary. It's in a bouquet of treatments that is offered. And if you try to tell them that this is the only treatment that will work for you, it doesn't work for patients. So
Right.
you have to explain that this is one of the choices. Similarly, when it comes to insulin, you have to explain to patients that this is the issue at the moment, and the important thing is to get your sugar down quickly so that you don't have any immediate complications from high sugar. And if you want, I'll ask some person to come and explain to you how the insulin is given, etc. Generally, I find I can. Sometimes, of course, it doesn't work, but generally, I find I can get through that way. Trying to find out what the reason for the patient's refusal is.
Right. I think it's quite helpful. I hope that answers Dr. Iyer's query. One last question before we close. It's around remission. You did mention about your patients seeing remission or reversal to some extent, and do these apps actually help people achieve remission? Because that's what most of them promote when it comes directly to the patients, right? Talking about remission in a complete go, and there is still a lot of talk around it, right? Whether it actually happens, it doesn't happen. So with your vast experience, what do you?
My experience has been extremely positive. Of course, you can't expect 100%. Some people are extremely motivated. They'll follow your instructions to the last letter.
Right.
And the number of remissions I've seen is very high. In Dr. Dikshit's program, I'm regularly involved in seeing patients in a free OPD. And we've seen that about 30 to 40% of patients go into remission with 2 meals a day. With that, of course, you have to make sure that they're not eating sweets and a lot of rice, and they're not overloading on carbohydrates. So a combination. With Fitterfly, I've seen people go into remission. So the thing is, the Dikshit pattern of diet of only 2 meals a day may not suit everyone. So you have to, it's not one size fits all. You have to identify what works. And remissions are a reality. I would have not been very convinced about it 5 years ago, but now I've experienced it enough to see that, of course, if the patient goes back to their old habits, they'll relapse. But as long as they're sticking to the diet, they stay in remission without any need for medicines.
I think that's great. And a lot of appreciation for you on the chat as well from the audience. So thank you so much, Dr. Nitin. I think this was a very insightful discussion, a lot of take-home messages for our audience. And we all, I think, have learned how to truly be patient-centric and also not shy away from technology. So thank you so much, everyone, for taking out time from your OPD today. And thank you once again, Dr. Nitin, for your time and wonderful insights. Yeah.
Thank you. It was a pleasure.
Can I ask a lot of questions, please?
Yes, please.
Yeah. What is the legal aspect of the e-records? Some say that editing is possible, including names of patients, etc. What is your take on this?
I didn't get that. The legal aspect of what?
Editing of e-records.
Editing of e-records. I think most of the records that are now coming up and are being promoted are compliant to a certain set of standards. There's a long list of letters. There is some, like the American standards. So once you've made an entry into that at a particular time, after a certain time lag, you cannot edit it. So that part is taken care of. So you're not able to re-edit it afterwards.
Yeah, sometimes what happens is the doctor maintains the record. It is difficult for another doctor, for some reason, if the patient has changed the doctor, for sharing of previous records. The previous doctor may not be agreeable to it, and vice versa. So in that situation, the patient gets very embarrassed.
Yeah.
So what is the solution to that?
I think for all my patients, I give printed prescriptions as well. Besides the electronic record is there, but their new consultants, if they want to, that is one aspect. And I think soon there is a legal framework that is coming that the patient will have control of their records. So they will have a password or OTP based password system. So they will be able to open their electronic record with any doctor that they go to. So that is coming up soon.
Okay, and my last question is that what happens is that the use of artificial intelligence by patients, like for example, you said about costing of, for example, professional fees or cost of medications. Patients go through this Pharma One app, Pharma Ease app, and also treatment options they Google or whatever, and they find out options, and then they, kind of argue with you saying that no, that was the line of treatment, that was the standard of care. You have given some other thing. What do you suggest as a senior person? How do you deal with such situations?
I think use of Google and technology is going to keep increasing. What we have to make sure that is we spend enough time with the patients. I think that is the biggest thing. I find a new consultation can't happen unless we spend about half an hour or so. So we have to spend enough time with the patients, discuss that. Sometimes even the patient might give you a thing and might point out an error that might be correct. They might point out something that you might want to modify. I find that, and I'm very open about accepting that. If someone points out something, I said, let me look at it. And if I feel that I've made an error, I will go back and correct myself. I think that is the best way. Have very open approach is what I feel. And time is the other thing. You have to give enough time to the patient. I feel we'll be increasing fees in proportion to the time spent. That is what we are increasing our fees. So I have increased my fees almost 100% or more in the last 3 years because I'm spending a lot more time. I can't see 40 patients. I'll see 30 patients only. So I think we have to calibrate the fees to the time spent with the patient. And that's one way out of it. I'm sure there are lots of thoughts about this. And I feel personally that giving extra time to the patient and then I find that I'm talking to so many relatives, a relative from America, a friend, someone who knows me, who knows the patient, that type of thing. You just have to be patient, smile, and sometimes you have to tell them, look, I've talked already to 2 or 3 people. If you want to discuss anything more, please go and talk to those patients, those people. And I won't be spending more time. I tell this to the patients or the person who comes to me with a smile, with trying not to get angry with the patient. So that is something we have to deal with. Mobile people will ring you on the mobile for inquiring about different patients. Confidentiality is also an aspect in this because a patient's friend might call you and want to know, and you're not sure who it is. So I flatly say, I won't share information with you on the phone. If you are interested, please go and talk to the patient, or you come with the patient the next time he's coming. So that is what I tell them.
So, and one more point is that solo ethical practitioners like you may not be advertising, but corporate hospitals on your behalf advertise. What is your take on this? I find it very embarrassing at times.
Yeah, I don't know. I'm still struggling with this idea, whether advertising is ethical. At least you have to have some presence on Google so that your clinic location is known. There are various companies also that come and you give us 10,000, 20,000, 30,000, we'll put your name first in the rankings. So I stay away from that type of thing. And I find I have enough work without getting into any of this. If I went into that, I would have 50 patients and I wouldn't be able to see any of them properly. So I say my work level is only so much. I can see only 30 patients in a day reasonably and still have time left for myself. So I stay away from these things. There are many. There's no need to name those. I'm sure all of you are very familiar with these things. They're marketing gimmicks basically. So I think the best thing is word of mouth. People find your name even if you don't advertise in any of the companies. They'll find your name on the web. That much is there every day, and then word of mouth works very well. I'm still not decided in this. For my younger colleagues who come and ask me, do you think I should, because there are so many practitioners and I don't get enough patients? So I said, you decide that. As long as you're not doing anything wrong to the patient and you're spending some, like you're spending for your clinic infrastructure, if you feel it is important, you do it. But don't make sure that for that you're not doing anything that would be justified for the patient. Like ordering tests and things that you don't feel are really warranted. I hope that answers some of the questions, Dr. Borkar.
Yeah, thanks.
Thank you.
Great. Thank you so much once again, Nitin, and thank you all of you for attending this and making this quite interactive. Yeah. Thank you so much. Have a great evening. Thank you.
Thank you. Goodbye.